All right, so we're recording today's lecture, and trauma was also uploaded to Blackboard, and you should have received a link for it as well. So in this session, we're going to look at the slow rhythms or the non-electrical rhythms. Now, again, one of the things that it's important for you to do, and I realize this goes all the way back to your 303, but make sure you understand the conduction pathways of how the electricity or the dromotropic effect of the heart moves through the cardiac tissue. Because this is going to help you tremendously when we're looking at, in particular, rhythms that are bradycardic and trying to understand where they're coming from. Here's the thing to keep in mind. There's going to be some things that you're going to do that will be very helpful to increase the heart rate. In other situations, if you don't understand where those rhythms are originating, what you do for your patient is just simply going to waste time. We'll talk about that when we talk about, do I give atropine or do I use electricity here in just a little bit. So as we're going through and we're addressing that, SA node, and then it comes down to the AV node, into the bundle of His, and into your bundle branches. Now, again, today we're going to take just a little bit of a touch into heart blocks. We're not going to look at EKG rhythms, but what we are going to do is, first of all, understand the pathophysiology behind heart blocks and understand that this is going to be one or multiple parts of either the left or the right bundle branch. And then lastly, it gets down into the Purkinje fibers, which depolarizes the ventricles. Understand that the atria, when it depolarizes and contracts, it contracts from the top down, okay? The ventricles, on the other hand, contract from the bottom up. The reason that it does that is that is the most efficient way to move the most blood from the atria into the ventricles, and then from the ventricles into the lungs and out to the body, all right? So when we're looking at this, symptoms of bradycardia typically begin to occur when there's not enough blood that is being ejected from the heart to meet the workload demands of the heart itself. Now, what would be some of these symptoms, particularly early on, that you would expect to see when a patient has symptomatic bradycardia? An altered mental status. And again, I want to stress to you, altered mental status may be just something as simple as confusion, or it could be potentially your patient is unresponsive. What else? Say it again. Fatigue, okay? This is really important here when we're looking at this because, again, this is going to be, Colin, one of the earliest signs or symptoms that your patient will often report, even though in shock, an altered mental status is going to be one of your earliest signs and symptoms. Fatigue is going to be one that's going to come into play because not only now is the heart not meeting the workload demand or the workload demands of itself, the heart, it's also not meeting the workload demands of the different muscles. What did you say? Hypertension? Hypotension. Yep. So that would be a drop in your blood pressure, and we would see this. The other thing that you might see would be shortness of breath. Now, Ryan, one of the things that and again, this is where the art of medicine comes into play. I wish I could give you a checklist and say, okay, when your patient hits these three symptoms, your patient is always going to be considered symptomatic. No such checklist exists. So what you're going to have to do is you're, number one, going to have to go on your experience, Bella, and number two, you're going to have to go on, I've got to do what is the best for my patient in the particular situation. If you let those two principles guide you in everything you do, then you will rarely make a mistake. Didn't say never, but I said rarely you would make a mistake. Other symptoms that you would see your patient having are palpitations. What are palpitations. Say it again? Okay, tell me a little more though. Give me a little more detail, Martina. Okay, so maybe like a skip beat, okay? Now, we can have palpitations when the heart is too slow. We can also have palpitations when the heart is in SVT or VTAC with a pulse, okay? So many times patients will just simply say, Miriam, it just kind of feels like my heart's skipping a bunch of beats in there. And a lot of that comes about as a result of the patient not having enough contractile force. The heart is contracting, but the patient doesn't feel it as strong as some of the other ones. Exercise intolerance, and by exercise intolerance, it doesn't mean out running or walking on a treadmill. It just simply means the actions of everyday living. Being able to go out and walk 20 yards out to your mailbox and back now becomes a huge problem for your patient, okay? And so that's one of the things that they will be able to, won't be able to do either. So now understand that bradycardias can present either as a left or right bundle branch block as well as vesicular blocks. Now, one of the things I want to point out to you, when we're talking about vesicular blocks, as you look over here, okay, and this is not the best illustration in the world, but over here we have branches of nerves that begin to break off, even into the end of the septum. And those are called fascicles of the left and right bundle branch, okay? So we can get a fascicular block, we can get a bifascicular block, which means two of them has a block in it, or we can actually have a trifascicular block, which means three of them are blocked, and that can lead to problems with the ventricles depolarizing. So again, when we're looking at hemiblocks, that's what we're talking about, okay? When we're looking at bundle branch blocks, we're basically looking at a problem down here in the septum. Now, if your patient is having ST elevation in what leads, would you think that we would more commonly see bundle branch blocks? V1, V2, very good. That's your septal leads, okay? Anytime that you're looking at either elevation or ischemia, you got to be or a depression of your ST segment, you got to be thinking about, does my patient have a bundle branch block, okay? And if they don't have one now, can they develop it? Important thing that you need to remember, if your patient has a left bundle branch block in the presence of a STEMI, and the left bundle branch block is new, the mortality rate for that patient is about 75%, okay? You might want to write that down, all right? Now, you cannot always get that information from your patient because the patient may or may not know what you're talking about. Miriam? Absolutely. So if you have a patient that's having a STEMI, okay, regardless of where it is, but they're having a STEMI and you notice a left bundle branch block and it's new, okay, your patient has a 75% mortality rate. So you need to be watching your patient really closely. So basically what you would do in that situation is you need to ask your patient, anybody ever told you have a problem with the conduction system or the nervous system of your heart? Do you have any blocks? A lot of these patients will carry a little cardiac card that has a laminated card that has their 12 lead on it. And they'll pull that out and you can look at it and it'll give you the diagnosis. If this is an old left bundle branch block, you can go, okay, probably not going to work a cardiac arrest today. All right. But if you identify that this is new, then watch for your patient to go into cardiogenic shock. Again, why would that be, do you think? Now think about your knowledge of pathophysiology from your 2 semesters of A&P and what we've learned in here from 303 and 310 about pathophysiology of the heart. Why would there be an increased mortality rate so high with this type of condition? Colin.
Because the contractions of the left ventricle is not going to be occurring most likely if there's a new onset of the infarction, plus the actual onset of branch block. It's not going to let the muscle depolarize correctly.
Yeah. Good, very good. Because remember, when we're looking at MIs in the patient, we're really concerned, Rehana, about the left ventricle, because that's where most MIs occur. When we have death of the left ventricle, we lose contractile force, and we're going to have some concern in here about this not working. And now that all comes together to raise the level of your patient going and dying on you before you get them to the hospital. All right, so you want to kind of keep that in mind. Now, here's the thing to keep in mind. When your patient has a bradycardia, depending upon what causes it, there may also be a loss of the timing between the atrial contraction and the ventricular contraction. Now remember, this is your atria, here's your ventricles, and typically what you're doing is you're looking like this. Also remember, we talked about in 303 that said, if you have a blockage or dead tissue, what are the 2 things that it does not do? Okay, so it doesn't conduct electricity and doesn't contract. Now, if it doesn't conduct electricity, the impulse still has to get through the heart to depolarize it. So what does it do? It takes the long way around. That's going to throw off this type of rhythm here. If that rhythm is thrown off, even for a fraction of a second, what's that going to do to our cardiac output? Yeah, it's going to decrease it. It's going to decrease it. That condition of when that occurs is known as AV dysynchrony. Dysynchrony. Dys meaning difficult or off balance, and synchrony is lining things up, synchronized. Think about one of the Olympic events that's known as synchronized swimming, okay? You watch these ladies get into this pool and they do everything and it's timed perfectly, and it's really pretty cool to watch. But if one person is off, you go, oh man, that person's way off, and that throws off everything. So AV dysynchrony will have that particular situation. Basically, the timing of the atria and the ventricles are offset. Not a lot, but just enough to reduce the amount of blood that is ejected from the atria down into the ventricles. If we reduce that amount of blood, we're going to reduce what? Our preload, which means our cardiac output is also going to go down. Ryan?
Would you be able to notice this on a rhythm strip?
You wouldn't be able to notice it on a rhythm strip because the only way you can pick that up would be through going and do an electrical physiology study. Basically, an electrophysiologist, which is a special type of cardiologist, can go in and outline the heart. Now, so why am I telling you this? Well, once a patient's been diagnosed with it, that should be part of their history that they're going to tell you. So if they say that, they have AV dysynchrony, or they say, my heart doesn't beat in rhythm, this is probably what they're talking about as far as being offset and reducing their cardiac output. Does that help? Okay, call it. I suppose theoretically you could, but remember, it's not going to get, if it gets off a lot, your patient's going to go into most likely VTAC or VFib just simply because of the maladjustment of the electrical impulse through it. So keep in mind what you're actually hearing are valves opening and closing in the heart. And so the biggest thing that we would do is that just knowing that our patient has this, and if we have a decrease in our patient's blood pressure, knowing that that could potentially be the cause. Now, there's not anything that we can do about it. There's not anything that a physician can do about it. They just watch the patient very, very closely. Probably the biggest thing a physician would do would be to put the patient on a beta blocker or maybe even a calcium channel blocker to try to put it back into alignment. Good questions. Anybody else? Okay. Now, when you are having AV desynchrony, basically what's going to happen is what is known as a Cannon A wave, Cannon, Cannon A wave. And basically what happens here is that the atria contracts against a partially closed AV, what's the word I'm looking for? A valve, atrioventricular valve. So the valve is partially closed, the atria contracts, and what it does is it causes a reverse wave that the patient can literally feel. Okay, so it kind of comes back up into their chest. Have you had one before?
Yes, many of them.
Okay.
I feel like it's blowing air into each other.
Okay, so that's a good example. All right. So and part of this can come about as a result of just normal physiology, but we see this most often with AV desynchrony. Literally, the atria is contracting, and the valves are partially closed, which means they're going to get some back pressure, and you're going to feel that back pressure, kind of like. You have any firefighters in here? Okay. What's a water hammer? Do you know what a water hammer is? Yeah, and what else is possible to happen when you slam your nozzle closed too fast? So where else will that backflow of pressure potentially go? Perfect. Yep, you're exactly right. So that's exactly the same thing. So if you close a nozzle too quickly, it causes a water hammer and it sends an impulse back to your engine, which can, in certain situations, cause damage to the pump and the engine. Now, you don't have to worry about it causing damage to your heart, all right? So it's not going to be that bad. But the same premise exists here with a Cannon A wave, okay? Cannon A wave. I want to write that one down as well. The biggest issue that we see with a Cannon A wave would be, and when we say wave, we're actually talking about a pressure wave, not an electrical impulse that you would see on your EKG. What's the biggest problem that you think that you would see when your patient has a Cannon A wave? And we see this primarily in patients that have really slow rhythms. What would be the problem? As a result of what? Afterload would actually drop, because remember, if you have decreased cardiac output, pressure is also going to fall. But the big thing would be here a concept known as a decreased atrial kick. Now, here's the thing to remember about physiology of the heart. When the atria contracts, the last little bit of the contraction is even more forceful than the first part of it. That last part of the contraction of the atria is called atrial kick. And what that does is it's trying to get all the blood out of the atria down into the ventricles that it can possibly get in there. All right? When we have the situation of a Cannon A wave, your atrial kick goes away, and you are right, it's going to reduce our preload, which is going to lead to the potential of a drop in cardiac output. All right. Now, the biggest thing we're going to be concerned about here is how does this affect the heart and the brain? Martina.
Does it stretch out the atrium more?
Ooh.
And then it would
Okay, so now remember, stretch receptors are located in the lungs, okay, to keep them from overinflating, okay? We have baroreceptors in our carotid arteries as well as in the aortic arch to measure the blood pressure. But that's a good question. Is it possible that this could lead to a stretching of the atria? And tell me what the name, whether it does or not, tell me what the name is of that particular condition, the medical. Yeah. Cardiomegaly, yeah. That's an enlarged heart. That's what the problem was with the Grinch. Remember, it says his heart grew 3 times larger. Well, he has cardiomegaly. All right, you'll never be able to watch the Grinch Stole Christmas the same way again now. But is that possible with our patient? We know it can happen in fiction, but can this lead to cardiomegaly in our human patients? Say it again. That's not the right answer. If it goes for a long time, yes. Okay. And so this would be this is one of those situations where physicians will try to use beta blockers and calcium channel blockers to reduce the negative impact from that particular situation. All right. Now, let me stop here because I just gave you a bunch of new information. Are there any questions about what we talked about, in particular, AV desynchrony and Canon A waves? I am recording this, yes. Okay. Cardiomegaly? Cardiomegaly is an enlarged heart. Cardio, heart, megaly, large. So, Bella, go ahead. Because remember, we're getting back force up into the atria. So the atria is stretching beyond what it's supposed to because we're getting that back force. Much like Bella did. She gave us a good illustration of a water hammer, of that force coming back and expanding the pump on the engine or the truck that's pumping our water out. The exact same thing happens within the heart, so it can stretch it out. Man, I got hands all over the place. Okay, Colin, and then here, and then here. It hits up against a partially closed valve because there's a problem with the dromotropy of the atria is quicker than the dromotropy of the ventricles. Now, what did I just say? The speed of the impulse. So if the impulse is slower in the atria and the impulse is faster in the ventricles, remember when the ventricles contract, and the left ventricle makes up how much of the heart? What percentage? 75%, okay? And so when the left ventricle contracts, it's going to have much more force than what those two little teeny tiny atria are going to be. We've got some pig hearts in the freezer, and one of the things I want to do over in the freezer in the other room. So one of the things I want to do in the spring for 360 is that we're going to have a heart dissection lab, and you're going to go in and you're going to tear these hearts apart and look at the structures, because a pig heart is almost identical to the human heart. So ladies, when you say men are pigs, you're not far from being wrong, okay? Now, the other thing to keep in mind here, though, is that because the ventricles contract with much greater force, that's going to close those valves and expand the atria.
Why doesn't it go up to VDK?
It does. Remember, that's that Canon A wave that Muna has said that she's felt. They can often feel this impulse in their throat and sometimes in their head. Why not down here? Because the vena cava is larger. The inferior vena cava is larger because it's got to bring back more blood. So it has an ability to expand more. And the superior vena cava breaks down into the EJs, external jugulars here in the neck, as well as coming up into the head. Sydney.
Is this something we can smell on it, or would it be?
This would be something that your patient would tell you that they've got going on, that you would pick up on your history. Again, when you started this class, I told you we were going to get really, really deep into patient assessment, and part of that assessment is getting their history. So this would be something the patient would be aware of, and even if they're not aware of it, it's still going to show up as slow heart rate and reduced cardiac output. Because remember, what happens to the heart rate when we increase the pressure in the heart? Say it again, Aziz. It decreases the heart rate. Why?
Because there's so much volume in there already, it doesn't have to work as hard.
If it's a cardiac output where basically if the stroke volume goes down, then the heart rate goes up. And if the heart rate down,
Say it again, Taki. This was all the way back in 303.
I've slept.
Obviously. The answer starts with the letter V.
you talking about the Vegas? Well, we gotta talk about the Vegas now. I feel like you're talking about.
When we increase pressure in the heart, what else does it put pressure on? When we take a deep breath, what happens to your heart rate? Why? There's pressure on the vagus nerve. So when we get that backflow that comes up in there, our heart rate begins to drop.
We thought you was going deep, so we didn't think we were gonna do that.
Apparently, I got to go all the way back to the beginning. Rihanna, you've been waiting patiently. Okay, if it comes back, let me know. Sydney, did you have anything else? Okay. All right. So, okay.
How long does the heart can tolerate the pressure of the atrium?
It all depends. It depends. Okay, so it depends on the age of the patient. It depends also, does the patient have any other heart problems? And in particular, what we're looking at here, does the patient have any problems with the valves, with the AV valves? Now, one of the nice things about this is that if the valves wear out, they can be replaced. That's relatively simple cardiac surgery, okay? Relatively minor based on surgeries today. But what we want to try to do is to keep that pressure down. So again, that's why your patient would probably be put on a beta blocker and a calcium channel blocker. Beta blocker to try to bring that impulse back into alignment, a calcium channel blocker to reduce even more the contractile force of the heart. Good discussion. All right, so when we're looking at bradyarrhythmias, bradyia means slow rhythms. Basically, we're looking at several different classifications, okay? One of them is related to impulse formation. So let's look at a rhythm strip and take a deeper look at this, okay? What is this rhythm? Sinus arrest, not block. Sinus arrest. Why is this sinus arrest and not block? Peace to you too, sister. Why? Yeah, there's more than one rhythm that is, or there's more than one QRS that is in block, okay? Now, if we're looking at impulse formation, and understand, on your final exam, I may give you one of these things and simply say, identify this rhythm. If it's a bradycardic rhythm, I'm going to ask you, tell me what classification or why is it doing this? So what we're having here with impulse formation, what does that actually mean? Oh, you're going to sneeze.
And it's gone. It's because it's not from the examples from the
It's not getting from where?
essay.
Yes, you're correct. So there's no impulse that's being formed, okay? If we at least had electrical activity in the SA node or somewhere else in the atria, how would we see that? Say it again.
You're gonna see atrial,
People with
restart of atrium.
Yeah, if we get an impulse that comes out of the atria, but it doesn't go through to the ventricles, what would we see there? Say it again. A P wave. A P wave. Yeah, very good. So we would at least see a P wave. But up in here, we don't see anything, okay? So that tells us that we've got a problem with atrial depolarization. The atria itself is not firing, okay? This leads into periods of asystole. When else might you see this particular type of rhythm after you've given a particular treatment to your patient? Boy, you are on a roll today, young lady. Yes, except we would see this being what? Probably twice as long. Probably twice as long. Why? Because adenosine wipes out the electricity in the SA node and the atria itself, okay? So that's exactly what we would see with this particular rhythm. Now, here's the thing. Your patient may say, ooh, I felt that. Or if they have a bunch of these, this could lead to your patient having a syncopal episode. Now, these, when I say syncope, what is that? You're going to faint, okay? Most of the time, when your patient faints, as soon as they get prone on the ground, they wake right back up. If this is the problem, they don't wake right back up, okay? Because it will continue. Now, let me ask you a question. I don't mean to put anybody on the spot, so don't call anybody out. But you guys have been doing IVs on each other, right? Has anybody passed out yet? Okay. A couple of cohorts back, I can remember one of the students, he's a medic now, doing great, and they were doing IVs on him, and you could just watch. He was sitting in a chair up in 286, and you could just watch as they were getting ready to stick him, watch the blood just drain out of his face, and his eyes perfectly just kind of rolled up, and he slumped back and slid down, and we caught him and put him on the ground. As soon as we got him supine, he woke right up and was very embarrassed. Shouldn't be, no big deal. It happens to all of us. This is not what you're going to see with your patients, okay? This is going to be as a result of your patient not having enough ventricular contractions to lead that. Now, if your patient has a bunch of these, what do you think is going to be the ultimate treatment for your patient? A pacemaker. Good, Devin. You're right. Because it's going to have to be artificially generated. Sinus bradycardia, okay, now we call this one sinus arrest. It is a problem of impulse formation. Sinus bradycardia is also a problem with impulse formation, all right? It doesn't generate enough of the beats. Now, your patient can be symptomatic or they can be non-symptomatic. This is solely looking at the electrical impulse and whether it is being formed correctly. So when we're looking at this, basically what happens is that you begin to have a disconnect between the patient's ability to exercise. And again, in medicine, when we talk about exercise, we're not talking about what you would do early in the morning when you go to the gym. Just the normal, everyday activities. It would lead to what's called exercise intolerance. Why? Because this is our patient's heart rhythm, and our patient, if this is their resting heart rate, and they're not an elite world-class athlete, they're not going to be ejecting enough blood from their body to be able to go about and do what is normally needed. If a patient's body is put under stress and the heart rate won't go up, it becomes even worse, okay? So that's what we mean by exercise intolerance for our patient. Now, this is very, very common in cardiac patients who have had MIs that have affected the electrical system of the heart. This is why a lot of these patients have to go in and have pacemakers put in. And remember, what's the difference between a single chamber and a dual chamber pacemaker? Yes. So the single doesn't go to the atria, it goes to the ventricles. Okay? Single one goes to the ventricles, dual chamber goes to both. Taki. So how does it do what now? As far as the pacemaker? Without the pacemaker, basically your patient's heart rate, again, think about what if you're sitting here right now and your heart is beating fast enough and strong enough to meet your oxygen demands. You go out and you walk up those stairs, your oxygen demand for your body is going to go up. But it's an issue of supply and demand. If you've got a patient that has this rhythm or lots of these, then because of the overall rate is going to drop, it's not going to be able to increase enough to meet the demands that you put on it by going up the stairs. Well, our choice in both this rhythm and this rhythm would not be epinephrine to begin with, but it would be atropine. And we'll hold on to that question because we will hit that question soon. Okay, I keep thinking, okay, we'll do it on Thursday, but we got the exam on Thursday. Okay, so we'll get into that. Okay, now again, as you're looking at this, we can also have a syndrome that is known as Tachy-Brady syndrome. Basically, what is happening here is that we have these long impulse or long segments of asystole, which means how much cardiac output we have going on here? Zip, zero, okay? And then our heart rate picks up and goes really, really fast. How much cardiac output do you have going on here? Not enough, okay? We don't know exactly how much, but not enough. How do we know that? Because that's following the problem that we've got in here. And then it converts and we begin to see these other areas in here, again, of these long periods of asystole. This, if you see this is early formation of what rhythm? Say it again. Say it again. It could be PSVT, but probably not with these long pauses. Go higher. Atrial fib. Atrial fib. Because look at this. We have very irregular over here, and then we've got asystole, but look at our line. That could potentially be atrial activity that's going on, which means we've got a quivering atria, but we have no ventricular output. Then it kicks into overdrive, and now we begin to see these smaller gaps that come into play here. And then it repeats itself with a very long gap, which is very similar to the pattern. So this is a good indication that your patient could potentially be going into AFib. Now, again, what drug do we consider administering for AFib? A beta blocker. A beta blocker, all right, to get our rhythm back into order, okay? Not until you get it back into order, okay? A calcium channel blocker. Now remember, with AFib, we're not talking about a blood pressure problem, okay? But what we are talking about is an irregularity problem. And so AFib, beta blocker is what we would start out with. And again, I tell you this because some of y'all already work in hospitals, so I remind you of that. Now, some of the sinus bradycardia causes, make sure you're familiar with this slide. I won't ask you to give me all of them, but I will ask you to tell me some of them. So for example, if your thyroid is not active enough and you have hypothyroidism and it's not ejecting enough of the hormone that comes with a thyroid, everything's going to be slowed down. Your heart rate will be down. Your blood pressure will be down. And you will feel tired all the time. This is one of the things that they go in and they check when a person has depression. because what that does is it slows everything down, and that can lead into depression. And so they'll go in and they'll check your thyroid, all right? Second thing would be certain types of drugs. We know that beta blockers will reduce that. And generally what happens with beta blockers is they're primarily going to be given either for AFib or for what other condition? We're high blood pressure. We are going to follow up our MI patient with a beta blocker, okay? Depending on what your protocols are, but that's what the standard of care is now. But when you go in for hypertension, it's kind of, you look to be about that big, let's start you out on this. And invariably, it'll either be too much or too little, and so they have to go back and adjust it. If they give the patient too much and they slow the heart rate down too quick or too low, then we're going to have this cause of bradycardia. Vomiting. Vomiting does what to cause the vagus nerve? The vagus nerve. The same thing occurs when you have a patient that is sitting on the commode having a bowel movement. The vagus nerve gets activated and the heart rate drops. This is why you see so many older patients who have their cardiac arrest in the bathroom. They go to the bathroom, they're constipated, they're bearing down, heart rate drops down, they go unresponsive, they go into cardiac arrest. Ryan. Benzos do have an indirect effect on heart rate in the fact that they typically will initially cause an increase because of hypoxia. Benzos, basically the big thing we're concerned about with benzos is knocking out the part of the brain in the brainstem that controls our respiratory drive. And so when we start to become hypoxic, heart rate will go up. Then eventually, if we don't have somebody there to support that with a BVM, then it'll start to come down as your patient goes into full cardiac arrest. Sydney. Usually they've got usually two things that happen. Number one is that they're usually going to be on a beta blocker, and number two, they already have an extensive cardiac history. So it's not one of those things. I'm not telling you this to scare you all, okay? You're not going to have to worry about this, all right? But basically what you're looking at is, again, older people who are on a beta blocker who have had an MI with fairly significant damage, particularly right down through the septum area. Good question, all right? Other things, increased intracranial pressure. Remember, in head injuries, we have what three symptoms that we're looking at? What's it called? Cushing's triad, which is what? Increased blood pressure. Say it again. Irregular respirations and bradycardia. And bradycardia, okay? Hypoxia, hypothermia. Hypoxia and hypothermia initially will cause an increase in your heart rate, but as it gets worse, they will begin to drop down. Infections, obviously, because of the way that the body is working, especially if you get a patient that has sepsis. And then finally, clinical depression can cause a decrease in your heart rate as well. Part of that is physiological because of the action of depression, as well as some of the medications that you will see. Again, go back in your textbook and review, please, the action of the vagus nerve, because many times a bradycardia is caused by vagal nerve activation. Yes, ma'am.
So with the vagus nerve, it starts all the way up to what, the ninth, 10th cranial or whatever, and it goes down, right?
Somewhere like that, yeah.
Okay, so if it comes down to that, it's parasympathetic, if it's hitting off of there, is it more symptoms happening besides just lowering the heart rate because of the muscarinic type of receptors that they hit? So if they hit all of them, that's like saliva, or, other stuff that has to do with that goes on also, because when you sit on the toilet, it's using your muscarinic receptors. So also your heart rate is going down, muscarinic receptors. So is there other stuff that's going on besides just lowering the heart rate?
So the big thing that comes about would be think of all the symptoms that come attached to an insufficient heart rate. And that's typically what leads to those symptoms. Altered mental status leading to unresponsiveness. A slow heart rate, which leads to decreased preload, which leads to crappy cardiac output, leading up into your unresponsiveness and your patient going into cardiac arrest.
So would it be like for vomiting, wouldn't it have to do with that as well?
Yep. Yep. And so, again, that's one of the things. Remember, we talked about inferior wall MIs? And I said that one of the things that you will see with inferior wall MIs is often your patient will vomit and vomit profusely. And remember, we don't want our MI patients vomiting. We want to give them some Zofran to take that away from them. Number one, it's good for the patient, ultimately. Number two, it doesn't mess up the back of your truck. Okay, let's be practical here. So you can kill two birds with one stone. So you want to wipe out that nausea and vomiting so that it preserves the heart rate, okay? Now, remember we talked about what was the problem with sinus arrest and sinus bradycardia. What was the cause of that problem? Impulse formation or formation of the impulse. I don't care how you put it, okay? Second one is going to be impulse conduction. Now let's think about this for just a minute. Ryan, what set of rhythms should you already know that would be classified under problems with impulse conduction? Absolutely. So we have first degree, second degree type 1, second degree type 2, and third degree block. Okay, let's look at these really, really quickly. Now, I'm not going to go back through and reteach you EMC 303. You already know that, okay? Basically, first degree block is just a delay of the impulse as it gets through the AV node, okay? Most of the time, it's not going to be a problem. There is probably about 5 to 10% of the population that has first degree block as a regular occurrence. If you've got children, it is highly likely, especially if they are younger than 10, that they already have a first degree block. Why? Because their conduction system has not yet completed development. So it is very, very common to see this in young children. So if you get called and for whatever reason you put a patient on a pediatric patient on a monitor, you see a first degree block, you go, oh, well, Bill said that was going to be that way. All right. So first degree block, not a big issue. Okay. Second degree type 1, now we're starting to get a little bit of concern. Basically, with second degree type 1, we have intermittent blocking of the atrial impulse at the AV node. Now, again, we have two types of second degree block. We have type 1 and type 2. If you had to choose which one to take, go with type 1. It's still considered a low degree block that is not nearly as dangerous as second degree type 2. Why would there be the difference? Why would second degree type 2 be more concerning and listed as a high degree block and second degree type 1 would not? That would be one thing. What else do you normally see with a second degree type 2? Say it again. Which leads to what? If we have more dropped, what in particular? What part of the beat? Now, we get plenty of atrial conduction, but ventricular. So we have more dropped ventricular beats. If we reduce the ventricular depolarizations, then we reduce the ventricular contractions, and then, ladies and gentlemen, we reduce what? Preload, cardiac output. Excellent, okay? As you're going up the list of your blocks, again, we're looking at third degree block. Third degree block is basically it used to be called complete heart block. Basically what's happening is the atria is doing its thing, everything gets blocked off at the AV node. The ventricles going back to that property of automaticity that says what about the heart? Every cell in the heart can generate its own impulse. The ventricles realize, hey, we got to do something. Atria's not working. We got to do this. So the atria will fire at its intrinsic rate, which is 60 to what? 60 to 100. So your atrial rate will be 60 to 100. Your ventricles will fire at its intrinsic rate, which is what, Danny?
I'm sorry, I was.
I know you had that 1,000-yard stare, okay? Somebody help him out. What's the intrinsic pacing rate of the ventricles? 20 to 40. So when you're looking at your rhythm and you see a bunch of P waves and you see a little bit of your QRS waves, you need to immediately begin to think, I may have third-degree block going on here. This, again, leads into severe reductions of cardiac output, okay? Yes, ma'am.
So that's like, I know first degree, like, but if we leave first degree block, like, as it is, and you did say there's people that actually survive that way. But if you go to second degree, like, does it just, like, eventually, like, how it would be, like, compensated to finally get to third degree block where they're not even reaching each other, or?
If your patient is in second degree type 1, most of the time physicians will just simply watch them, okay? Second degree type 2, if it is not taken care of, and usually we handle blocks by doing what? A pacemaker. If it is not addressed, it will progress up into third degree block, okay? All right. So what I'm going to do is I'm going to stop there because what I want to give you at least 15 minutes to look at your exams.